Hello, I am Erwan Lerumer, a physiotherapist based in Paris, and I am pleased to welcome you to the weekly Pelvic Health Research Review for the 25th of July, 2026. This week, 78 publications were analyzed and 12 were classified as Level A after curation. The main feature asks a very practical question. In pelvic floor rehabilitation, how much treatment is actually needed to produce a useful effect? This review provides general scientific information and does not replace individual medical decision-making. The must-read papers of the week. Our first must-read looks at manual rotation and maternal positioning for persistent occiput posterior position during labor. A network meta-analysis pooled 15 randomized trials involving 2,934 women. The authors compared manual rotation, hands and knees positioning, lateral positioning, and standard care. None of these strategies showed a statistically significant benefit for spontaneous vaginal birth, cesarean delivery, severe perineal trauma, or low APGAR score. Lateral positioning produced the highest point estimate for spontaneous vaginal birth, with an odds ratio of 1.97. However, the credible interval ranged from 0.83 to 4.88. Certainty of evidence was low to very low. That is precisely why the paper is useful. An intervention can be biomechanically attractive and still remain clinically unproven. Our second must-read concerns perioperative gabapentin after benign anorectal surgery. 6 studies, including 504 patients, were pooled. For pain at 24 hours, 4 studies representing 415 patients could be analyzed. Gabapentin was associated with a mean reduction of 2.1 centimeters on a 10 centimeter visual analog scale. The Bayesian analysis gave a 99.8% posterior probability of benefit. However, heterogeneity reached 99.2%, and overall certainty of evidence was very low. The message is therefore more interesting than a simple statistically significant p-value. There is probably an analgesic signal, but the true magnitude and reproducibility of that effect remain uncertain. Statistical significance does not automatically mean ready for routine practice. Our third must-read reports 5-year patient-reported outcomes from the PACE-B prostate radiotherapy trial. Men with localized prostate cancer had been randomized between stereotactic body radiotherapy and conventionally fractionated radiotherapy. At 5 years, urinary outcomes were similar between groups. 64% of men in the stereotactic group and 69% in the conventional group reported being completely leak-free. However, 91 and 90% respectively were pad-free. A patient can therefore be pad-free while still reporting occasional leakage. Erections adequate for intercourse declined from 35 to 17% in the stereotactic group and from 40 to 20% in the conventional group. Moderate or major bowel problems remained around 5%. Calling someone continent or pad-free does not tell exactly the same story. Our fourth must-read asks what urinary function looks like after pelvic mesh removal. A New Zealand cohort included 345 women who underwent mesh explantation, on average almost 9 years after implantation. Pain was the most common indication, followed by lower urinary tract symptoms or bladder outlet obstruction. After removal, stress incontinence, pain, or overactive bladder persisted in 30 to 40% of patients. 20% still reported dyspareunia, and 12% obstructive voiding symptoms. Most strikingly, 48% required at least one subsequent incontinence procedure. 6 women ultimately underwent cystectomy. Mesh removal can be necessary and beneficial without restoring the patient to her previous baseline. Functional morbidity may become chronic. Our fifth must-read examines the levator hiatus from pregnancy to 8 years after first delivery. 183 initially nulliparous women were followed from 21 weeks of pregnancy to 1 year, and then 8 years after their first delivery. 3- and 4-dimensional transperineal ultrasound was used throughout follow-up. In women with at least one vaginal birth, levator hiatus area increased overall between pregnancy and the 8-year follow-up. In women who delivered only by cesarean section, it decreased. The interesting point is that after a first vaginal birth, another vaginal birth did not appear to further increase hiatus area during Valsalva. The first delivery, therefore, seems to play a particular role in the morphological trajectory of the pelvic floor. The model is not simply one of linear damage accumulating with every birth. Main feature: pelvic floor rehabilitation. How much is enough to change something? The first paper, and probably the strongest in this section, is a randomized trial of autonomous bladder training for neurogenic bladder. 168 adults were allocated either to routine rehabilitation alone or to routine care, plus a 4-week structured program. The program combined induced voiding, sensory awareness training, pelvic floor muscle training, bladder sphincter coordination exercises, and bladder desensitization. At 4 weeks post-void, residual volume fell more in the intervention group, with an adjusted between-group difference of minus 55.8 milliliters. A reduction of at least 50 milliliters occurred in 79.8% of participants versus 42.9% of controls. Maximum flow rate, selected urodynamic measures, and neurogenic bladder symptom scores also favored the intervention. Symptomatic urinary tract infections requiring antibiotics were reported in 9.5% versus 27.4%. That result requires caution because microbiological confirmation was incomplete. Some benefit appeared to persist at 12 weeks. A relatively short, structured, and multimodal program can therefore produce a clear functional signal. The second paper asks whether an even lighter intervention can work before prostatectomy. A prospective comparative study evaluated a single-group pelvic prehabilitation session before robot-assisted radical prostatectomy. The session lasted 60 minutes and included pelvic floor anatomy, proprioception, supervised contractions, and prescription of a home training program. 214 patients were included, 107 before implementation of the program and 107 after. At 6 months, 82% of patients in the prehabilitation group were completely pad-free, compared with 66.7% in the control group. Urinary function scores were also better. The study was not randomized, so parallel changes in surgical or follow-up practice cannot be excluded. Still, the idea is important. One well-designed session may be enough to provide the right cues and launch effective self-training. The economic analysis estimated a net saving of about 165 euros per patient. The third paper looks at endometriosis, supervised exercise, pelvic floor training, and sexual function. 81 women with laparoscopically confirmed endometriosis and pelvic or genital pain were randomized. All attended a pain management course. 41 also completed 4 months of weekly supervised general exercise, including pelvic floor muscle training, together with home exercises. At 4 months, total sexual function scores were higher in the exercise group, with a mean difference of 3.52 points. Lubrication and orgasm scores were also better. However, differences disappeared at 12 months, and there was no significant benefit for sexual pain itself. Most importantly, the design cannot tell whether the effect came from general exercise, pelvic floor training, or the combination. The program produced a short-term benefit, but the active ingredient remains uncertain. The fourth paper is about access to care. A Quebec survey included 3,822 women who had given birth within the previous 4 years. More than 95% reported at least one pelvic health problem lasting more than 3 months during pregnancy or after childbirth. Yet only 50.4% of women with pelvic health problems had consulted a pelvic health physiotherapist. The main reasons were believing the problem was normal and would resolve spontaneously, not knowing physiotherapy could help, and not receiving a referral or recommendation. Access was greater among women with higher income or university education, and after severe perineal tears, diastasis recti, or pelvic organ prolapse. An effective treatment has limited population impact when half of the people who may benefit do not know it exists. The fifth paper asks what makes patients stay in a rehabilitation program. Women with pelvic floor disorders completed 6 sessions of manometry-based biofeedback training. The main predictor of continued engagement was not ease of use or general satisfaction. It was perceived usefulness, the feeling that the program was actually producing a meaningful effect. Self-efficacy, confirmation of expectations, and early engagement also mattered. Privacy and comfort concerns reduced satisfaction and indirectly reduced intention to continue. Taken together, these 5 papers make the same point. The dose of rehabilitation is not simply the number of appointments. A brief intervention may work if it teaches something precise and triggers autonomous practice. A longer program depends on content, adherence, and access. Brief reports. After surgery for stress urinary incontinence, urgency may improve, but it may also appear. In a registry including 2,710 TVT procedures and 305 Bulkamid injections, 79% of women with mixed incontinence reported improved urgency after TVT compared with 54% after injection. Among women without preoperative urgency, de novo urgency occurred in 6% after TVT and 20% after Bulkamid. A new anal insert device, Stay Sure, was tested in patients with moderate to severe fecal incontinence refractory to conservative treatment. Among those reaching the treatment phase, weekly episodes fell from an average of 5.4 to 2.1. 76% achieved at least a 50% reduction, and 54% achieved at least 75%. No treatment-related serious adverse events were reported. However, the fitting and run-in process substantially reduced the number of patients who actually entered treatment. The French Association of Urology has published 2 complementary guidance papers on bladder pain syndrome. Diagnosis remains one of exclusion, based first on history, examination, questionnaires, and phenotyping. Treatment begins with education, behavioral measures, pelvic floor physiotherapy, and psychological support. It then progresses according to phenotype towards medication, bladder installations, hydrodistension, botulinum toxin, neuromodulation, or, in extreme bladder-centric disease, surgery. For pessary use, a small French study found that 39 of 87 women interviewed had stopped using the device. After adjustment, previous hysterectomy, associated urinary symptoms, and especially stress incontinence, unmasked by prolapse reduction, were associated with discontinuation. The adjusted odds ratio for the latter was around 10. However, the confidence interval ranged from 1.46 to more than 200. An interesting signal, but a very imprecise estimate. At very long follow-up, midurethral slings remain effective for objective continence. A narrative review of 17 studies, each with at least 10 years of follow-up, found objective cure rates commonly above 85 to 90%. However, storage symptoms become increasingly important over time. De novo overactive bladder reached 41.6% at 20 years in some cohorts, and transobturator mesh exposure increased with longer follow-up. In motor incomplete spinal cord injury, 81% of 58 patients had fecal incontinence, constipation, or both. Half had delayed colonic transit. Around 64% had anal hypocontractility, 57% recto-anal coordination disorders, and 60% rectal hyposensitivity. Yet symptoms, neurological level, and physiological abnormalities overlapped poorly. Clinical history alone does not always reveal the underlying mechanism. Finally, a United Kingdom survey reminds us that urinary incontinence can change physical activity behavior. Among 410 respondents, around one-third said leakage influenced their decision to start an activity. 37% said it influenced whether they continued. Women with more severe symptoms reported less vigorous activity. The study is cross-sectional, so causality cannot be established, but the practical message remains useful. Leakage does not only interfere with sport, it may also push people out of sport. Let us finish with the unusual paper of the week. A 5-year-old boy had developed a huge scrotal swelling over 6 months. Clinically, it looked like a hydrocele. Ultrasound suggested fatty tissue. An MRI performed elsewhere had been interpreted as an omental hernia. Inguinal exploration found neither hernia nor fluid. Scrotal exploration finally revealed a well-encapsulated lipoma measuring 14 by 12 by 7 centimeters, located between the dartos and the skin, and extending towards the pubic arch, penile root, and pelvic floor. Even in a region we think we know by heart, anatomy sometimes gets the final word. Conclusion: this week's strongest papers offer less of a therapeutic revolution than a lesson in measurement. An attractive intervention may fail to show an effect. A statistically positive result may remain too heterogeneous for routine use. Surgery can correct one problem without erasing all functional morbidity. And in rehabilitation, quantity is not everything. A single well-designed session may sometimes launch a useful trajectory. A sophisticated program, on the other hand, is pointless if it is inaccessible, poorly understood, or abandoned. The right question is therefore not only how many sessions are needed, it is what information, what exercise, and what level of support are necessary to create a change that the patient can actually maintain. Join me next week for another review of current pelvic health research.